Hello, good afternoon. Just hoping that everybody can hear me. Thank you for joining us this afternoon for a little run around the menopause, women's health, and the services you might need as you progress through the menopause. Some of you might have met me. My name is Helen Cannon. I'm a family medicine consultant working at Medi-Clinic Airport Road. And I'm going to talk for about 20 minutes, and then I'm going to introduce Dr. Amer Elbaba, who's our very lovely Urogynae who's joining us this afternoon, who gives us a lot of support with women's health. And he's going to talk for 20 minutes about how he can help us too. And then there's going to be a bit of a 20-minute question and answer session. So please, if you have any questions, jot them down and then ask us towards the end. We're very happy to answer any questions that are important to you, and we'll go through them all together. So I know we'll have other people joining us, but as we're running to time, I think it would be a good idea if we could start. So just to introduce myself a little bit, I've been a family medicine consultant for 20 years. I'm not too happy to admit how long, but I was a GP back in the UK and have been a family medicine consultant here for the last 7 years on and off. We've been providing menopause care at Medi-Clinic for about the last year, and it's become apparent that you women generally want a bit more from us than the ad hoc menopause care that we're offering. And so we're looking to launch a menopause clinic. And this is really an introduction of our menopause clinic launch. So this talk is going to be focused around really what women want and what you want out of life and a service. And what I notice when I see menopausal women is that they come with many questions, many uncertainties. So I've collated a few of those questions, and I'm going to center my talk around your questions that I've gathered over time. So the first question I often get is, am I menopausal? How do I know? And do I need tests? What does this mean for my long-term health? Am I still fertile? Do I still need contraception? Do I need HRT? Is this something I need or should I have? And can I have HRT? What are the benefits? And I've read a lot about the risks. I've heard on social media and in the news about the risks of HRT. And actually, I'm not sure I want HRT. So what are the alternatives instead of HRT? And I've been taking some vitamins. Is it the right thing? Is that what I should be doing? What alternative vitamins should I take? So these are some really common core questions that I hear all the time. And so we're going to start with these, and I'm going to target each slide to each question. So am I menopausal? So there's the National Institute of Clinical Excellence, which did a review of all the literature last done in 2015 about menopause treatment and diagnosis. So menopause was defined as the permanent cessation, the stopping of menstruation, that's periods, due to the loss of ovarian follicular activity. That was the definition. And they said if you've stopped your periods for about 12 months, you can pretty much say that you are in the menopause. So the average age of this process is 51, but there's a huge spectrum of variety. And the menopause generally goes on for about 8 years. So you may just stop your periods abruptly, and 10% of women just stop, but 90% of women start, or they stop for a few months and then restart. And this is all quite normal. And the whole process can take an 8-year transition. The perimenopause is the time around the menopause and when the onset of symptoms and changes start. And the perimenopause can take up to 4 years to approach menopause. Could you just put your sound on silent for me? Thank you. The perimenopause is defined as the onset of sweating symptoms or any symptoms of the menopause, and when it's associated with a change in cycle. The premature menopause, however, is defined as between the ages of 40 and 45. In other words, you're going through the menopause too early, and it can hail symptoms of the menopause and changes of your menstrual cycle or stopping, and that's between the ages of 40 and 45. But premature ovarian insufficiency, in other words, insufficiency of estrogen, is defined as being under 40. And these are just the three definitions you might hear: premature ovarian failure, premature menopause, perimenopause, and then on to menopause. They're really arbitrary, to be fair. And to be honest, it's all hailed with the change in your menstrual cycle and physical symptoms of the menopause. What are the physical symptoms of the menopause, and how do I know? So I found this rather funny slide, but to be honest, it trivializes the symptoms of the menopause, and it makes me rather frustrated and a bit agitated in myself. But it does indicate the 7 commonest symptoms of menopause. So dry skin, dry eyes, dry vagina, irritability, sweats, insomnia, bloating and GI disturbance, forgetfulness, brain fog, mood swings. So those are the 7 dwarfs of the menopause, but that really trivializes what women experience, because in addition to that, you can get migraines, vertigo where the room is spinning, inability to retain facts and perform within the workplace caused by brain fog, low sex drive, otherwise known as low libido, joint and muscle pains. You can get bladder problems with urinary incontinence, stress incontinence, urgency, and these all contribute to many symptoms of the menopause that are quite debilitating for women. Looking at the facts of how many women suffer with menopausal symptoms and how they manage it, there was an Ipsos Mori survey done in 2016 that showed that 50% of women between 45 and 65 had actually gone through the menopause within the past 10 years, and they had not consulted a healthcare professional. And that's despite women being surveyed having more than 7 different symptoms. And even 42% said that their symptoms were worse than expected. So 50% of women are going through menopause, struggling with these symptoms, not coming to the medical professionals, not asking for help, and just struggling on. I thought that was really quite sad, and something we need to change, and something we need to do something about, and obviously offer help. So this data, as you can see, is by something called the Women's Health Concern. Women's Health Concern is an educational arm of the British Menopause Society. They're both accessible online. And if you particularly like the way these data are produced and formatted, then there's many more of these online, and you can look at them. It makes the statistics more digestible and easier to understand. Talking about relationships. So this was interesting. This was a study done, when was it done? In 2000s, I think, of mostly British adults. It was surveyed, 1,000 adults were surveyed, 1/3 of whom were men, and feedback about relationships at the time of the menopause. And it showed that, interestingly, 28% of partners say they often end up having arguments with their wives or other halves because they don't know how to help with menopause, with the symptoms of the menopause. And partners are left feeling helpless. So not only is this affecting the woman, but it's also affecting their relationship and having an impact on their partner. And again, this is causing significant morbidity. When every woman goes through this, 50% of women go through it silently. And I think this is something that we definitely need to be considering changing. So, do you need tests? Well, as described before, the menopause is diagnosed predominantly over the age of 45 with only symptoms. So As soon as you're over 45, you'll be getting some symptoms of the menopause probably, and your menstrual cycle will change. And that is enough to make the diagnosis. We don't need to do any tests once you're over 45, you're in menopause zone, and we can make that diagnosis just clinically. And dependent on what symptoms you've got, we tend to keep the woman at the center of our care, at the center of the choices that we offer to women. And so the spectrum of symptoms are also analyzed and assimilated, and the treatments are tailored towards the symptoms and the woman's choices about what she wants to do. So over 45, no blood tests required. Between the ages of 40 and 45, then we take it from the symptoms, but we may also need a hormone test called follicle stimulating hormone, FSH. And under 40, we need to have a family history of premature menopause, because premature menopause runs strongly in the family, in female relatives, obviously mother and sisters. And also we would need the hormone profile, when we tend to do it on 2 occasions about 4 to 6 weeks apart. In other words, if we get one normal result, we will go on to retest. So what does it mean for our general health going through the menopause? So the menopause is a breakdown of communication between the hypothalamus in the brain and the ovary, and the signals just don't connect, such that we get ovarian failure and we get estrogen loss. And that has a widespread impact on other systems in the body. So going from top left, the vasomotor symptoms are flushing, symptoms of anxiety and panic come alongside with that. Urogenital atrophy, so vaginal dryness, low libido, soreness, vaginal laxity, we can get prolapse, urinary incontinence. Obviously, we're going to lose our menstrual cycle, but we may be suffering with irregular, heavy bleeding. To the right-hand side, then we can get mood and sleep changes, cardiovascular risks increase, cardiovascular disease increases, and then the effect on the bones with bone thinning causing osteoporosis and the increased chance of us having fractures. So fertility also reduces, but it doesn't stop at the time of the menopause. So the advice is over the age of 50, we only need 1 year without a period to be able to say we are no longer fertile. But under the age of 50, then we require 2 years of no periods before we can say we no longer need contraception. And if, because you're on hormonal treatment, your menstrual cycle is continuing, then the advice is that we would continue contraception up until the age of 55. And once 55, even if you're still menstruating, you're not likely to be fertile, so you can stop contraception. Remember, HRT, hormone replacement therapy, is not contraception. So if you take hormone replacement therapy, you may well need contraception as well. And the recommended contraceptions for menopausal women would be the barrier, like the condom, or the IUS, the Mirena coil, or the progesterone-only pill. And women may already be taking the combined pill, the combined oral contraceptive pill, the progesterone-only pill, but that can be changed at the time of menopause. Some good resources for information for you I guide my patients to. So one is menopausedoctor.co.uk. Many of you may be already aware of this. And there's also an app that comes with this website called the Balance app. You can track your menopausal symptoms, and there's a lot of evidence-based, up-to-date information. There's also Menopause Matters, the British Menopause Society, who also produces the Women's Health Concern. That's the website I've been referring to, and the DAISY Network. Now, the DAISY Network is particularly good for women who go through premature menopause or premature ovarian failure, and that's for younger women who go through the menopause. Then there's quite a lot of information on social media. I know perhaps some of you are already connected with the Facebook page, Middle East Menopause Organization, which is run locally. And that's mostly a sharing of experiences of other women who are going through the menopause, talking about availabilities of treatments and what services are available in the locality. It's a very useful site. And from these sites, we can gain advice about lifestyle advice, whether we should be doing weight-bearing exercise, what clothing you should be wearing, cognitive behavioral therapy, triggers to symptoms, what pelvic floor exercises are and how you should manage them, whether you need calcium and vitamin D, whether you need vaginal lubricants or vaginal moisturizers, emollients, and also help with contraception. So, do I need HRT? Well, HRT really is only licensed for 2 indications. One is for menopausal symptoms, and the second is for osteoporosis. So if you have a diagnosis of osteoporosis, then HRT would be licensed and appropriate for your use. And if you have menopausal symptoms, but we don't tend to prescribe HRT hormone replacement therapy just to keep us young or to reduce risks of dementia or cardiovascular disease. It's only licensed for those 2 indications. And this is an enormous oversimplification, but to make sure that women are aware that if you have a uterus, women without a uterus, those women that have a hysterectomy would generally only need estrogen, and those women with a uterus would need estrogen and progesterone as their makeup of HRT. And the reason I'm stressing that is I have seen a couple of women come to me who have been on estrogen only HRT, but who do still have a uterus, and therefore that would increase their risks of the side effects of hormone replacement therapy in the way of endometrial hyperplasia. So and that's endometrial cancer. So you have to make sure that you're on the right form of HRT. Can you have HRT? Well, most women can have HRT. Obviously, we take a good history and a good family history, and we put it into context of what the woman wants, but also what her familial risks and personal risks are. And we would consider it in caution with women with breast disorders that are not breast cancer, like fibroadenomas or fibrocystic disease. If you have a history of deep vein thrombosis, migraine, gallbladder disease, or endometriosis and fibroids, then we would still consider it, but putting it into context and weighing up the risks and benefits. And then it's contraindicated if you have a personal history of estrogen-dependent cancers, and those can be breast cancer or ovarian cancer or endometrial cancer. Also, if you have abnormal vaginal bleeding, or if you have uncontrolled blood pressure, cardiovascular disease, or if you've had a thrombosis. So the benefits, just scooting quickly through the benefits of hormone replacement therapy, obviously it's aimed at symptom control and licensed for osteoporosis, but the transdermal hormone replacement therapy has also been evidence-based and shown to cause an improvement in your cardiovascular risk for the first 3 to 4 years. We call this the cardiovascular window. It only applies to transdermal hormone replacement therapy, and it's not long-lasting. It's also been shown to be good for your mental health and to reduce risks of dementia and improve sexual function. The downside of hormone replacement therapy, obviously we all know about the breast cancer, endometrial and ovarian, but also we have to have a bit of caution in reigniting endometriosis or feeding fibroids with the estrogen that we replace. And the non-body identical, the bioidentical or the oral HRT can increase your risk of cardiovascular disease, stroke, and clotting. Just about breast cancer, this is a good pictogram that puts it into context. So this looks at 1,000 women. It's taken from the UK, where we have a very wide demographic of women, and therefore, it applies to most demographic backgrounds. Women aged 50 to 59 in a 5-year period. So 23 cases of breast cancer are diagnosed in 1,000 over 5 years in that age category. And if we were to give 1,000 women hormone replacement therapy, then it would only increase the number of breast cancer cases by 4 on top of the 23 background. And interestingly, when you look at alcohol consumption down here, then you can see that if you drink more than 2 units of alcohol a day, then the risks of drinking alcohol are far in excess of the risks of taking hormone replacement therapy over a 5-year period. And other risk factors is BMI. If the BMI is over 30, then the breast cancer risk is significantly raised over and above the background and over and above the risk of combined hormone replacement therapy. And looking at the bottom line, exercise, if you're doing moderate exercise for 2.5 hours a week, you can actually reduce your breast cancer risk by 7 women out of 23 in a year, in 5-year period. So exercise can actually reverse the impact of taking combined hormone replacement therapy. And that applies actually to all cancers. So if HRT or hormone replacement therapy is not for you, then what alternatives are there? And there's quite a lot on the websites that I've given to you about what safe alternatives there are to hormone replacement therapy. And there's a list of many options. I'm not going to go through each one, but the top one is a beta blocker. Then there are some antidepressant medications that are actually listed and are helpful in mood disorder and also in reducing flushes. St. John's wort is over the counter, and then the isoflavones you might have heard of, red clover and soya. We have to be a bit cautious about these alternatives to HRT because they're not without risk. And some of the ones that you can see that are starred are not safe if you have a history of estrogen dependent or breast cancer, or if you're on tamoxifen. Cognitive behavioral therapy is also a non-hormone treatment that has been shown to benefit regarding mood disorder, but also has been shown to reduce flushes. And acupuncture has been shown to be very helpful with the joint pains and the mood disorder that women experience. And then the vitamins, there are particular vitamins that are tailored towards menopausal women and are configured specially for the menopausal phase. Menopause and Well Woman 50 are multivitamins that you may consider taking. So the ones in the dark script are all evidence-based. The ones at the bottom are something you might read about, but there's no evidence behind them, and therefore we don't know about evidence and safety. The logo at the bottom right is THR. It's the kite mark for traditional herbal registration, and it indicates the testing, trialing and safety of any medication. So if you're going to take anything over the counter or buy anything from the health food shop, make sure that it displays this kite mark. So thank you very much for listening. I'm sure you may have some questions after that, and Dr. Amer is now going to follow me, and we'll join you again in the questions in 20 minutes or so. Thank you.
Thank you, Dr. Helen. Thank you. Good afternoon, everybody. I'm Dr. Amer Elbaba. I'm a consultant gynecologist, and I spend most of my time managing patients with prolapse, incontinence, pelvic pain, and bladder-related symptoms, all of which are directly or indirectly caused by menopause. Dr. Helen, could you be kind enough to stop sharing so I can? So yes, I'm a consultant gynecologist, and I worked in the United Kingdom for about 15 years. I was a consultant and an associate professor with the University of Leeds. My practice is based around menopausal-related conditions, especially from the urogynecological point of view, and I support a lot of women in endometriosis as well. So what is menopause? Dr. Helen did a very nice description of it. It's a natural event for every woman. It's also known as the change. It basically marks the end of women's ability to conceive. But the severity of these symptoms can be very, very variable. We understand that although to many women it's just the change, but to others it can have significant impact on their mental health, on their physical health, and it can be very unpleasant. So it's not just a change, is it? It does have a physical and organic impact on almost every organ in the woman's body. It affects the brain and it causes fogginess of the brain, as well as lack of concentration. It can also affect the skin, causing thin skin or a dry vagina. It affects the cardiovascular system. It affects the bones and cause brittle bones or osteoporosis. And of course, it affects the pelvic floor and cause bladder and prolapse symptoms. We are not perfect at all as a clinician in managing menopause, and this is an international issue. We admittedly have a lot of variation of practice across the globe, including Middle East and all other parts of the world. We understand and appreciate that accessing care is not always easy for you as women. Shortage of HRT stock and also non-HRT medication is a big challenge for us, as well it is for you. And although there are some recognized menopausal clinics around, however, these clinics are not always necessarily clinics which I would like my mother or wife to go to. They're not particularly holistic, and they may focus on one issue, but not take a holistic approach of the whole menopausal-related conditions. The clinics are usually fragmented, so you end up seeing a clinician and then they refer you to another, and you end up saying 3 or 4 before all of your problems are addressed. There is a big lack of a person who is in charge and taking a decision for you and liaising between these clinicians on your behalf. So what is the solution? Well, we are very, very excited to share the news with you that we are opening a menopausal clinic here at Medi-Clinic Airport Road. And what these clinics are, this is a dedicated clinic that is aimed to support you through the journey, through the change. The clinic will consist of many professionals who are very well trained, including doctors, nurses, and other healthcare professionals. This multidisciplinary clinic is focused around menopause, and it will make sure that we will follow evidence-based guidance and protocols from all around the world. But what is more important is that we will make sure that we approach you as an individual and take your needs and expectations into consideration. Menopausal Clinic is not just an HRT prescribing clinic. It is a holistic clinic that will offer a holistic assessment and management options to all the common conditions that could happen around the age of menopause. We certainly believe that educating you is the main part of these clinics. We will educate you and offer you all the information that will then enable you to make the right choice for you. Yes, we do have a dedicated team of people who are very passionate, like Dr. Helen and I, about menopause. But we all appreciate and agree that you will be the main part of these clinics. Everything will be focused around you, and your feedback to us will be very, very important. We are very aware of our limitation, and we appreciate that these clinics and services are very new. So it's only with you that we can improve and progress further. These clinics will be obviously supported by other healthcare professionals who are not necessarily based in the clinic, but they will be accessible. We will have named experts in breast cancer surgery, rheumatology, psychiatry, and other important areas of medicine. Since my background is endometriosis and pelvic floor, my role in this clinic will be mainly to support Dr. Helen and Dr. Ibtihal in managing these groups of patients. We know that endometriosis affects as many as 10% of general population. These women, they will probably spend most of their lifetime having pain, having heavy periods, and having a lot of implications of endometriosis. They reach the age of menopause, and unfortunately, they get hit exactly the same as any other woman. Unfortunately, there are lots of misconception about managing menopausal symptoms in endometriotic patients. A lot of these patients will be told that you cannot have HRT. And although this could be true partly, however, we now know that there are lots of different approaches and different medications that are safe for endometriosis patients. What is more important is to have an open discussion and a balanced approach. It's important to be seen by somebody who has a background of endometriosis, so your endometriosis is optimized and well managed before you need any treatment. And if a treatment is required for menopause, then it has to be the least invasive treatment that will improve your symptoms without increasing the risk of endometriosis coming back too much. There are lots of recognized treatments, and most women will have no problems. So what I'm trying to say here, just because you have endometriosis, it shouldn't deprive you from having menopausal treatment. And what is more important is balancing the risk and benefit and making an individual plan for you. Women who survive the breast cancer don't get any better treatment, unfortunately. And we know that there are millions of people around the globe who suffered from breast cancer and who are completely cured. We know that breast cancer prevalence could be as high as 9 to 11% in general population during the women life expectancy. So there are lots of these women who survive, they live normal life, they completely got cured from cancer, but they still go through menopause. The general advice is usually avoid HRT. But is that the right advice? The answer is no. So if we look at the studies that looked at the safety of HRT in women who survived the breast cancer, there are 25 international well-recognized studies. All of these studies, apart from one, showed that HRT does not actually increase the recurrence rate of breast cancer. There is only one study called Habits study, which showed an increased risk of recurrence. And even in that study, there was only 22 patients who had recurrence. All of the studies, including the Habits study, showed that HRT, even if it caused recurrence, it will not increase the mortality rate. So the message here is that HRT could be a potential option for managing menopausal symptoms in women who survive breast cancer. Of course, it's not the only option. However, it should be discussed. Risk and benefits should be openly discussed, and then the patient should be allowed to make an informed choice about her own health. It is on the basis of these 22 patients that HRT, with demonstrated benefits for so many aspects of women's health, is being denied to millions of breast cancer survivors all around the world. With my urogynecological hats on, I also want to focus on the bladder issue. Now, urinary incontinence and the bladder issues are very common in women. They affect about 50% of women. These women, they have experienced urinary incontinence, whether it's urge incontinence or stress urinary incontinence. These symptoms tend to become more prevalent and more obvious around the age of menopause. This is partly because the vagina becomes more dry, the bladder will subsequently become drier, and women will start experiencing problems which they may have had for a long time. Treatment with topical estrogen is often very useful and very successful. However, it's not always the only treatment which we will be advising. The aim is to use the Menopausal Clinic as a platform to explore women's symptoms and to diagnose things which are often very hard to talk about in a normal gynecological consultation. If urinary incontinence was diagnosed, then we would be advising women to do pelvic floor exercises. We believe that these exercises should be ideally supervised by a pelvic floor physiotherapist. And this is in keeping with the evidence that supervised pelvic floor exercises are superior to exercises that women often do by reading a leaflet off the internet. Medical treatment for urinary incontinence is often very, very useful with very little side effects. And there are so many medications that we often choose from. They are usually either anticholinergics, which will relax the bladder muscle, or a new group of medication called beta agonist, and one of the example is Menopausal. Not all urinary incontinence cases will improve with estrogen treatment, pelvic floor exercises, or medical therapy. There are a group of women who will probably benefit from minimally invasive surgeries in the way of Botox, which is often extremely supportive and extremely helpful for women with overactive bladder. A transvaginal slings, whether it is synthetic sling or autologous sling, is also a very recognized and successful treatment for stress urinary incontinence. We have the facility and the expertise here to offer even more advanced surgery for women who have severe symptoms, including laparoscopic colposuspension suspension. Pelvic floor weakness and prolapse is another issue which is extremely common in women, but also more common around the age of menopause. It affects as high as 50% of women, and unfortunately, only 10% of those women will seek medical help. The other 90% will suffer in silence. And what we are trying to do is to empower you to talk about these symptoms openly with us as part of this menopausal service, so we can help you if you are after any help or treatment, or at least counsel you about the implications and to try to minimize the long-term consequences if you are not keen on any treatment. Prolapse increases with age, and as you can see in the slide, that it is extremely prevalent, especially after the age of 60. Prolapse can be managed with very simple techniques. For stage 1 and 2 prolapse, all you need is pelvic floor exercises, and that will probably stop you from having an advanced form of a prolapse in the future. Supportive ring pessaries or Gellhorn pessaries are also very good and recognized treatment methods, especially for these women who are not keen on surgical treatment. For women who are either keen on surgical treatment or on whom the conservative options did not work, we would advise surgery. We here at Medi-Clinic are very proud that we can offer all the surgical treatment options that are recognized by NICE guidelines, including uterine preserving options or non-uterine preserving options. So in summary, I would like to say that menopause is very common. We appreciate it's a very challenging process in women's life, and we are here to support all women, regardless of their background, during this rather challenging and unpleasant period. Thank you so much.
Thank you so much, Dr. Amer. That was a really interesting talk and a really excellent overview and a summary of what we're hoping to provide for everybody here at Medi-Clinic. And I think overall, we're trying to provide a multidisciplinary approach to the management of the menopause. As you can see from Dr. Amer's and from my talk, the issue with menopause is the symptoms are so widespread and affect many, many systems, and therefore we can't possibly just narrow it down to one particular treatment. It has to be a multidisciplinary team of physios, dietitians, psychologists who can provide CBT, and people who are interested and wanting to help. And also clinicians who are available, who can support the service, who can look at all the possible symptoms that you present with, to enable you to minimize those symptoms. And for the period of time that you have symptoms, which may be 8 years or longer, that you're comfortable and confident with your care going forward. So I think if we could open the floor to any questions, Dr. Amer and I are very happy to answer any questions you might have. So very, very happy to answer any questions as from now. You might want to put it in the chat or put your hand up if you want, put a hand up if you want to ask a question. know one of the questions that might be coming up was relating to the availability of testosterone in the region. I know one of the social media sites was asking, please ask if testosterone is going to be available. So just a little update on testosterone. It is available in the UAE. However, the issue with testosterone is that even when prescribed in Europe, for the menopause, it's prescribed off license. In other words, it's not licensed for that particular treatment. And clinicians in the UK, for example, where I come from, feel happy and safe to prescribe testosterone for the appropriate patient. And the gynecologists do prescribe testosterone a lot. But in the UAE, we're just seeking some clarity from the Department of Health to ensure that prescribing testosterone for a lady who may be going through menopausal symptoms would be approved by the Department of Health. So we're seeking guidance from our clinical governance team at Medi-Clinic to make sure that we would be, it would be deemed appropriate and safe to prescribe testosterone to a female. So that is in consideration. We know testosterone is available, and we look forward to hopefully being able to prescribe that in the future. Dr. Amer, did you have any take on that?
No, I totally agree. I think the main thing with testosterone is to use it after we fully utilize estrogen first. So the patient needs to be on a full estrogen therapy on a maximum dose, because a lot of testosterone will actually, a lot of estrogen will be converted into testosterone. So unless there is a full utilization of estrogen, then it will be probably not indicated. There is a question from Daniela about, is the clinic open already? Can we book appointments? The online booking system is not yet open for Menopausal Clinic. However, you can choose one of the 4 clinicians and book an appointment directly with them. So at the moment, I think it's Dr. Helen and Dr. Ibtihal from the family medicine, and myself and Dr. Firoza Dawood from the gynecology point of view. So you can just go on our profile.
Sorry, doctor, and if she can send me her contact in the private chat, I can book for her.
Sure, thank you so much. But I understand there will be a separate Menopausal Clinic, booking system, hopefully in the future. Helen, would you like to take the second question?
Second question.
When will you?
So when will the clinic be launched? So it's imminent. We already have named multidisciplinary team clinicians. Obviously, the doctors we have allocated who are all menopause familiar. And then we have a named dietitian, psychologist, and physio who will join us in the team. And we anticipate that your first point of contact will be through one of the doctors. We've kept it shared between family medicine and gynecology because we really wanted you as the patient to choose who you wanted to see first. And then from there, depending on your spectrum of symptoms, we would then refer you on to either the psychologist or the named physio or whichever other members of the multidisciplinary team we feel would benefit your care. And therefore, it would be done on a referral basis. But your first point of contact would be your choice. In the Menopause Clinic. The Menopause Clinic is already accessible on the website, and the information is there on the website. And then you would make an appointment with the appropriate clinician of your choice. And from there, we would refer you on to the other multidisciplinary team members that we felt would be able to help you.
Next question is it possible for menopause to start at age of 40 or 39?
So the next question is it possible for the menopause to start early from the ages of 39 or 40? And absolutely, the menopause can start at any time. Obviously, under the age of 45, that would be an early menopause, and therefore we would be wanting you to have some assessment with some blood tests to make a diagnosis, and we would be encouraging you and thinking about what hormone replacement you may require to maintain your well health. So yes, it's possible the menopause can start early at any age.
Do you offer help?
Thank you so much for, sorry,
Checkup.
Dr. Ellen.
Yes, hello?
Sorry to interrupt. So that was my question, right? To start for menopause to start early. So I've been struggling quite a bit from the age of 39. And it's been like almost 3 years now, and no doctor can tell me exactly what's wrong with me. And my gut feel is telling me that maybe it's related to hormones or menopause or anything, but I'm at the point where I'm just so tired of going from doctor to doctor and no possible answer. And all they're doing is just loading you with all these medications that are just making you even more sick. So it's good to hear that you'll actually do a full test to see what could be wrong. So I'm really looking forward to visiting the clinic.
Good. So the other problem with menopause is that some of the symptoms can be very vague. You may just have fatigue or hair loss, and there may be other medical reasons underlying your symptoms that aren't necessarily menopause. And therefore, when you present to a clinician, we always have a wide range of diagnoses that we consider, not just the menopause. And so it's important, I think, that women are taken holistically and managed holistically, and their symptoms are taken on board such that we can consider the multiple diagnoses that can present with similar symptoms so that we get to the right diagnosis and then, fortunately, to the right treatment. So we look forward to seeing you, to perhaps doing a bit of unpicking.
Do you offer healthcare package for women, which includes menopause and fully body checkup?
So the next question is, do we offer a full health checkup and healthcare package for women, which includes menopause and full body checkup? We do offer a full comprehensive healthcare package, and it doesn't necessarily include menopause, but it is appropriate to a certain age. And those packages are available as screening packages, and there are 3 levels. There's either an essential, a comprehensive, or an executive package. And depending on your funding, you can choose what level of healthcare package you can have. And obviously, you will be seeing a clinician for those healthcare packages. And if it was appropriate that we took a diversion and went away from the healthcare package and moved towards menopause, dependent on your presentation, then that would also be taken into account. So another question, how do you know if you receive body identical hormones or bioidentical hormones? So the bioidentical hormones, you can actually look at the definition of body identical as compared to bioidentical. If you go to the Menopause Doctor website, there's a really good little web chat about body identical as compared to bioidentical. So the bioidentical hormones generally are tailored to your hormone profile, and they're not actually recommended, they're not evidence-based. And what a clinician would do who is prescribing bioidentical hormones, and mostly it tends to be compounding pharmacists that do this, they would take a range of blood tests that may or may not be relevant to your condition. They would look at what your blood levels are in each hormone, and they would then tailor a hormonal preparation. They would compound a hormonal preparation that you would take. Now, when we've looked at the evidence, and when you think about menopause, menopause is about symptoms and is about keeping the care and needs of the woman at the center of the consultation, whereas the bioidentical sort of pattern of treatment is about treating the hormone profile, not the woman. So more accepted clinical practice is to take a full history of the lady's symptoms and her family history, and then to give her evidence-based hormone replacement therapy if that's what she wants, or if she wants alternative treatments, we would talk about that. And then the evidence-based hormonal treatment is 17-beta estradiol, which is the estrogen that you've actually lost when you pass through the menopause. So no other estradiols are body identical. So the aim is to give body identical not bioidentical treatment. The evidence is all behind the body identical, and body identical is about giving estrogen that's identical to the estrogen you've lost through the menopause, and to give a progesterone that's also the same as the progesterone that you've lost. And that would be 17-beta estradiol and micronized progesterone, which is what you tend to get when you come and see us. Will there be a wide variety of HRT available? So will there be a wide variety of HRT? I'll take that one first. So we have all the ranges of transdermal patches available, and we have, which is body identical, and we have the body identical progesterone available. We did originally have the estrogen gel, but it was coming up extremely expensive. And often the estrogen isn't, although the insurance companies say that they cover the estrogen, we haven't been able to find the particular codes. We are working on that. And we do tend to find that women find that the progesterone is covered, but the estrogen they pay for. But there must be codes that are available, which the insurance companies are eluding from us at the moment. The gel was coming up extremely expensive, and I know it's very inexpensive back in Europe and in the UK, so I stopped ordering the gel, but I think we will be able to get that in the future, so we're trying to source a cheaper alternative. And then, of course, there's the Lenzetto spray, which has come out in the last year, 18 months, which is very popular, so we're trying to get that in stock as well. And the body identical progesterone is very available.
Will the insurance work?
Will the insurance work? So as I said, it's part of the same question in truth. If we can liaise with the insurance companies, and we've got our billing department working on it, then we hope that this will be covered by insurance. Obviously, some insurances just do not cover menopause, but of those that do or say that they do, we're anticipating that we should be able to get a clearer information about what codes they require. The codes that we're using currently seem to enable us to prescribe the progesterone, but some women can and some women can't get the estrogen on their insurance. But to be honest, I'm very happy to work with you, with your insurance company. I've had some ladies come back to me and say that it was all covered, no problem. And if you want to take up that issue with your insurance company, I'm very happy to work with you on that.
Will HRT be available through the Medi-Clinic pharmacy, currently traveling to Dubai for prescriptions?
So the next question is, will HRT be available through the Medi-Clinic pharmacy? It's currently available. 50% of the patients that I see on a daily basis are menopausal women, and some women, the majority of them, are wanting hormone replacement therapy and are very happy to be able to pick it up from our pharmacy. Any other questions? Any questions for Dr. Amer at all?
I think there is a question about perimenopause periods. Yes, you could very normally sometimes have a period all of a sudden, even after the age of menopause. However, we have to be very careful. So if you were bleeding free for over 12 months and you suddenly had a bleed, although this could be completely normal, but you should always get it checked by a gynecologist. So we will treat that as a postmenopausal bleed and do all the appropriate investigations before we reassure you. But the ovaries could sometime resume activity all of a sudden. And the other part of the question, could the problems of autoimmune disorders and the chronic diseases increase and get worse? Yes, they can. They can, and I have seen cases of arthritis and rheumatoid arthritis getting worse and becoming more kind of problematic around the age of menopause. And this is to do with the dryness of the skin and dryness of the tissue.
And in that case, the hormone replacement therapy wouldn't necessarily be contraindicated. And we know that the menopause in itself causes musculoskeletal problems, joint problems, trigger fingers. Many connective tissue disorders are caused by estrogen deficiency, which are reversible with estrogen treatment. Any other questions? We're very happy to answer any questions, no matter how how simple, small, or concerning that anybody has?
So I've got a question for you, Helen, Dr. Helen.
Go for it.
How common do you think menopausal problems are in UAE? Did you find any difference in observing these symptoms between the UK and United Arab Emirates?
So interestingly, the majority of my patients tend to be Western. Western women tend to declare their symptoms more readily. However, I have got a small cohort. I would say probably 1 in 10 of my patients are local ladies. And so I'm very keen to open up the service to Arabic speaking ladies. We did a webinar yesterday in Arabic, as you're aware. So I'm really keen for the Arabic ladies to come forward. Hopefully we're going to record this webinar and we're going to put it on the website. So those ladies that feel that they can't attend today will be able to access the information. But I think there is a huge untapped need for local ladies to access this service as well.
There is a question following up an autoimmune. Could menopause cause autoimmune? I mean, I don't think menopause can cause autoimmune conditions, but it can perhaps make them more symptomatic. Do you agree on that, Dr. Helen?
Yeah, totally. So obviously an autoimmune system is set by your immune system way before the menopause. Therefore all your immunological markers are already set. But from a symptom profile, you know, some of the symptoms of the menopause can make the symptoms of autoimmune disease more uncomfortable, because if they're of a similar ilk, then the symptoms just add together. Any more questions?
Dr. Helen, in your service, what is your threshold for asking for a Dexa scan to look out for osteoporosis in this cohort of patients?
So any patient who has a low BMI or family history or has a fragility fracture, if they present with a history of a fractured forefoot bone just with exercise and they're not overweight, if they've got any past history, then I would put, or a family history, I would put them forward for a Dexa scan. But routinely, menopausal women don't need a Dexa scan. It's only if they fall into those high risk categories. And Dr. Amer, during your Urogyne clinic, how many menopausal women are you seeing in your Urogyne clinic?
To be honest, back in the UK, almost 90% of my patients are women in their early 50s.
Yeah.
And looking back at what I used to do, the average age of surgery was about 58. But the onset usually of presentation to clinic is around 51, 52. So there is definitely an association between menopause and urogynecological problems. And this is very well established association. So it is very common. Here in UAE, just similar to what you have said, the average age of patients who come to me is probably in their early 40s. So people used to kind of complain about urogynecological problems well before menopause starts. I suspect, you know, this is just a, you know, probably due to multiparity, having so many children in Middle East compared to the UK. You know, the average UK parity is 2, while, you know, it's a lot higher here in UAE. So people tend to present much earlier.
And of those patients that present to you, how many would be managed with more conservative treatments like estrogen cream and pelvic floor exercises? And what percentage of patients that present to you would need surgery?
I would say 90% and 10%. So most women will go through the conservative route because either that's what they want or that's what I advised. I mean, certainly for women who just started menopause, we would always emphasize on topical estrogen treatment, pelvic floor exercises, try to get them through the difficult phase of menopause before we do anything invasive, really. But there are women who have already done that. So they come in and they are well educated, they know exactly what they have been through, and then we sometimes choose the surgical route.
Thank you. So there doesn't seem to be any additional questions coming up. So should we call it a day now? And thank you ever so much for joining us this afternoon. Dr. Amer and myself and our team are very happy to see you and go through your questions with you on a one-to-one basis. Thank you for spending some time with us this afternoon. I think the presentation is recorded and will be put onto the website under the Menopause Clinic heading. We'll be very happy to see you in the Menopause Clinic. Thank you so much.
And thank you, Dr. Helen, for your leadership in this important topic. Thank you so much.
Thanks a lot, Dr. Amer. Thank you.
Thank you.